30 seconds, Carly.
Okay. Good morning, everyone, and welcome to our policy forum with the Lung Health Foundation. My name is Carly Weeks. I'm a health reporter with the Globe and Mail who's spent the better part of this year covering all issues related to COVID-19. So I'm really happy to be moderating this chat today with Dr. Paul Wheatley-Price, who is the president of Lung Cancer Canada and a medical oncologist based in Ottawa. The way this is going to work is that we're going to have I'm going to have a discussion with Dr. Wheatley-Price. We will save a little bit of time at the end for some questions. So if you do have some, questions, get them ready for the end. And here we go. So, COVID-19 has disrupted everything in everyone's lives. It's also created some very serious challenges for a lot of individuals, as well as for our healthcare system. And we're certainly seeing that as we're, many parts of, Ontario are in the midst of this second wave. During the first wave, a lot of healthcare systems made the decision to, delay or cancel anything that wasn't an emergency, just to help preserve the healthcare system and make sure things didn't really get overwhelmed and shut down. We're starting to see a lot of the fallout from that right now. We're hearing stories about patients that have had, their cancer diagnosis delayed, people who haven't been able to receive treatment. And, I've spoken to many oncologists who said that they've been working very hard to make sure that a patient's, disease grading doesn't change during COVID-19 because of a delay in treatment. It might change because of the patient's prognosis. But that's been a very hard thing to accomplish, just given all of the challenges our system is facing. And for a lot of people with lung cancer, those issues are right at the forefront. I mean, not only are they facing potentially much greater complications because they're at greater risk due to their immune compromised state, but they're also facing things like, delayed treatments and delayed screenings or diagnosis. From a personal standpoint, I have a family friend who recently passed away as a result of lung cancer, and some of his treatments were not available to him in the last months of his life. And, it's been a very difficult time for a lot of people. So how has COVID-19 basically affected all of this? We're going to the expert now, Dr. Wheatley-Price, and just thank you so much for being here. And I think the question that all of us would like to know, and we were talking a little bit before everyone joined us, just, how COVID-19 has affected people with lung cancer. And you were saying, it's affected people differently. I was wondering if you could talk a little bit about some of the fallout and what we're seeing right now.
Yeah, good morning, Carly, and thank you very much for inviting me to be part of this discussion. I've had some Zoom training recently because we've been doing so many Zoom calls. I'm meant to be looking into the camera, not at your picture on the screen. So if you see my eyes flitting back and forth, I apologize for that. I think, from an oncologist perspective, I can speak to what's been happening in Ottawa, and we can maybe get onto that in a bit about how treatments have been adapted and impact on screening and research, etc., and surgery, chemotherapies, radiotherapies. But in my sort of Lung Cancer Canada role, I'm seeing it more broadly across the country, and I think we have to recognize it's very different depending on where you are in the country. So when that first wave hit in March, April, May, Montreal, for example, parts of Montreal were very badly hit and had much bigger impacts than other places in the country, and Ottawa was maybe somewhere in the middle. At the beginning, there were various fears, and some of them have come to reality to a degree, and others haven't. So, one of the fears was, if you have lung cancer, is your treatment going to be affected? Are there delays in surgery, chemotherapy, radiotherapy, etc.? Another fear was, if you have lung cancer, but you don't yet know you have lung cancer because you've just got some symptoms but haven't been to see your family doctor, or is there going to be an impact there? And so people get diagnosed at a later stage because they don't want to go to the hospital, or they don't want to go to the family doctor's office, or the office is closed, or they're nervous about going for tests and things. So there's these kind of two components about the people who aren't yet diagnosed and people who are already diagnosed. Maybe if we take that second group first, people who are already diagnosed with lung cancer, they're already sort of in the system. And there are then different components to that as well. So in Ottawa, we were really largely able to keep chemotherapies, immunotherapy, some of our newer treatments going. Radiation went on very well. There was a bit of a slowdown in surgery. And you can imagine that fears for surgeons or respirologists who may be doing tests which involve putting something down your airway, these so-called aerosolizing procedures, put the healthcare professionals at risk. And so a lot of systems were put into place very quickly to try and ensure that people could still get assessed and get their treatments, but making sure that the healthcare professionals were safe too. And I think in a lot of centers, actually, lung cancer's done okay. And in Ottawa, there was a slight slowdown in surgery, but largely caught up. And a lot of centers now are looking to ramp up their surgery, even to rates higher than pre-pandemic, because there's catch up to happen. But a lot of procedures around safety in the operating rooms and cleaning, et cetera, make it very difficult, and the staffing levels are impacted. Some of the treatments changed. So some courses of radiotherapy were shortened. Some doses of chemotherapy or immunotherapy we were able to give at bigger intervals. And those are changes that were kind of welcome, that we welcome, because we know that that's safe and it's effective. It's not reducing the effectiveness of the treatments, but it's allowing people to not have to come to hospital so much. So those were really good changes we could make. Mm-hmm. We've often in Ontario and in Canada being such a big country, virtual care like this or on the phone has got a lot of advantages for a lot of my patients who live 2-3 hours away. And for just a regular checkup, I don't necessarily need to see them in person. So moving to virtual visits was a big plus. And then we've learned as we've gone along who that works for and who it doesn't, and who we still need to bring to the hospital. So there have been some I would say some positive things. Our fear was, what do we do if we just can't give the service, even with changes? What do we do if we just don't have enough nurses in our chemotherapy unit because they're ill or isolating, or their kids have got sniffles and they've had to be in quarantine? And so cancer centers across the country went through very uncomfortable exercises of who gets treatment and who doesn't if we get to the point where we can't treat everybody. And fortunately, we went through those exercises, but most places never actually had to implement them.
I want to ask you about patients who haven't been diagnosed, but just very quickly, we're obviously in the midst of this second wave. We're seeing hospitals sort of filling up more and more.
Right.
What are some of your fears about the winter months and some of these, contingency plans maybe coming into reality?
Right, and I think that's the biggest fear that I've had for our lung cancer population as a whole. In Canada, we have up to just short of 30,000 anticipated lung cancer diagnoses this year. Actually, maybe I could just do a little diversion, do a shout out to Lung Cancer Canada. We just released our Faces of Lung Cancer report, which you can get on the lungcancercanada.ca website. And a lot of this information is in there, people, if they wanted to follow up, and there's a whole COVID section in there as well. But close to 30,000 patients anticipated to be diagnosed with lung cancer this year. And unfortunately, still the most deadly cancer in the country, around 21,000 deaths from lung cancer anticipated this year. And one of the problems is around 50% of people who are diagnosed with lung cancer, it's already stage 4, which is the advanced stage when they're diagnosed. And we've been calling it Lung Cancer Canada, along with many other groups, CPAC, the Canadian Partnership Against Cancer, for lung cancer screening to identify people at an earlier stage where the cancer is more likely to be curable. And what's happened with the pandemic is well, screening is not widely available in Canada yet anyway. British Columbia has just announced they're going to have the first program, which is great. In Ottawa, we did have a pilot program, but that closed, you know, that, and along with breast cancer screening and a lot of screening programs just went, you know, cold turkey, stopped in mid-March. And now they're reopened, but there's a lot of backlog. So we're a bit worried that people who might have been screened and caught at an earlier stage, with a delay in screening, that would be an issue. And then the other thing, as I kind of alluded to earlier, we're just worried about those people who may be starting to get symptoms. And common symptoms for development of lung cancer would be a persistent cough. So if you have a cough for more than 3 weeks, it's not going away, you should go and you should seek medical attention. And don't put it down to being a smoker's cough if you've been a cigarette smoker. If you've not been a cigarette smoker or you quit many years ago, it doesn't matter. If you've got a persistent cough, you should seek medical attention. If you cough up any blood, that's not normal. You should seek medical attention. And so we're a bit worried that people who may have had these symptoms have, you know, for very good reasons, and you know, they're worried, or it's difficult to access assessments, that they've not sought medical attention in the same way that we all normally would. This will only come out with time, but our worry is, instead of 50% of people being diagnosed at stage 4, might it during the pandemic be 55% or 60%? There was some modeling coming from, well, many places, but particularly some quite worrying statistics from the, or modeling statistics from the UK, that delayed diagnosis could really cause a lot of unnecessary fatalities in the UK. Now, we don't know if that will play out, but that's our worry.
And it's a huge concern. And you're right, so many unknowns, things that we just, you know, and we've never been in this situation before, right? So we're learning as we go, and, you know, seeing that some of the mistakes that we made early in the pandemic, hopefully we don't make again. And, you know, I wanted to touch back on that screening point you had mentioned, you know, basically screening programs being shut down, because before COVID-19 hit, there was something really exciting going on in various parts of the country. Well, you know, you mentioned BC and some parts of Ontario, you know, where Ontario specifically was piloting a lung cancer screening program. Maybe you can speak a little bit about that, and sort of how patients could be affected now for years, because this has basically been kind of put on pause for so long.
Yeah, I'd love to speak about that. And again, if you forgive me for just shouting out the Lung Cancer Canada website and that Faces of Lung Cancer report again, but this is our #1 advocacy ask in lung cancer, pre-pandemic and now, you know, still moving forward, is we would like lung cancer screening. And what screening involves is what's called a low dose CT scan. So, you know, someone goes into a regular CT scanner, but they change the software a little bit on the machine, so it's a very low exposure to radiation, so very, very safe. And what we learn from screening studies in the US and in Europe and in Canada is that without screening, I mentioned earlier, 50% of people are diagnosed at stage 4. It's around 70 to 75% either stage 3 or stage 4, with very low cure rates. But for people who are diagnosed through a screening program, 75% of those are at stage 1 or stage 2, where the odds are now really in their favor that the cancer could be cured. We're seeing some early data from the Ontario pilot program, which has been going on in 3 or 4 places in Ontario, including Ottawa, actually, just to shout out to my center. But the early data from that is similar, that we're catching lung cancers early. So really promising. And we were really hoping that CCO and the Ministry of Health in Ontario were going to you know, recognize that and roll out a provincial-wide screening program. It is long overdue. Lung cancer is unfortunately still in 2020 a stigmatized disease, and it's stigmatized at all levels by nihilism, unfortunately, still within some sections of the medical profession, judgment from the general public. 1 in 5 Canadians still think that lung cancer patients deserve less sympathy than those with other cancers. You know, there's this issue with the wrong question. You know, someone gets diagnosed with lung cancer, they get asked the wrong question, which is, oh, I didn't know you were a smoker. That's the wrong question. The right question is, I'm sorry to hear that. How are you feeling? Can I help? So sorry, I'm getting on a bit of a rant now, But,
Oh, please go on.
those issues feed in, I think, to why we've not seen screening programs more widely adopted now. They're available in the US, UK, and other European countries. British Columbia, hallelujah, thank you to BC, have announced the first province-wide program that will be coming in 2022. There's a lot of work to get that up and going. I would love to have seen Ontario make that announcement this year. They have been the leading province so far with their pilot programs. I like to think that they were going to do it, and there was a delay because everybody's focus moved towards COVID. But now we've got to start thinking about these things again. And so, if there are people from the Ministry of Health or CCO on this call, you already know what I think. But we'd love to see Ontario again show that leadership and bring screening in. It's cost effective. Diagnose people earlier, getting them through treatment is more successful, more likely to be cured, and it's cheaper than waiting for it to be an advanced disease.
That's such a great point. And I'm glad that you bring all of those issues up because, every time we talk about lung cancer, it does go hand in hand with stigma, unfortunately, still today. And I think that's one of the reasons it's been such a challenge to see any real, there's always been this struggle just from researchers I've spoken to in the past to attract the research funding. It doesn't have a pink ribbon campaign, it doesn't have breast cancer was once a very stigmatized disease as well. So there's things that can be done, obviously. But, it's obviously a huge challenge, as you say, most commonly diagnosed and one of the leading causes of cancer death, or if the leading cause of cancer death. So very important to get that done. And, I will say, we were actually speaking at the Globe and Mail about doing something on lung cancer screening, a big piece on this. And then obviously COVID hit. And, we've been writing nothing but COVID.
Here's your opportunity, Carly, to write it now. But
there
you're
you
right.
go.
But stigma, we've seen stigma, I think, successfully, the needle has shifted successfully with things like HIV and mental health and other diseases. And we still really got to fight for that for lung cancer. Pink ribbon campaigns for lung cancer have been a challenge because historically it's been such a deadly disease. And so there hasn't been a big population of survivors. But now, we've got great new treatments, immunotherapies, oral targeted therapies, screening. All of these things give us the promise that we're going to have a much bigger population of lung cancer survivors, which is good for them, of course, first of all, and their families, but also there may be some of them, we're seeing an increase in numbers of people who want to help, address these advocacy issues.
For sure. And that's a hopeful tone. And to sort of go back to one that's maybe a little bit more grim, you spoke about how, jurisdictions such as Ottawa have managed to really sort of, I think, weather the storm fairly well, figuring out what process is to put in place and to keep people safe and things like that. I wanted to ask a couple, sort of two questions. I'll start with the first. Are there some mistakes that you think, or things that we didn't know early in the pandemic that now we sort of realized we don't need to do that anymore? I think in some circles they're saying, well, maybe we should have kept some of our ORs operating, at least at some increased capacity, or there's certain things that are being adapted as we go into the second wave. And do you think that there's things now, basically, are we learning from some of the errors maybe that were made earlier in the year?
For sure, we're learning, for sure. I guess I'm a bit reluctant to call them errors because, this was such a new situation, and
that's fair. Yeah, that's
so much priority on trying to keep everybody safe. So, I think we've for sure have learned. And so, I was just speaking to one of our surgeons earlier, and our current surgical capacity is going up to about 115% of what it was pre-pandemic, but then it really dropped, and there were priorities on certain cases, and lung cancer was prioritized and was able to be, we kept that going. But there were other cancers, like prostate cancer and some breast cancer cases, where and you wouldn't want to have to say this to someone who needs their operation, to say, well, you can safely wait, or would have to have some other treatment to kind of hold things at bay before an operating room became available. And all of the non-cancer stuff has really been delayed. So I don't know if that was a mistake, but I think what the the operating rooms and the managers have learned is now how to be able to increase capacity and do that in a safe way, in terms of cleaning in between cases. And there are still challenges around hours and staffing levels with that. So I think we've learned that. I think we've learned a lot about virtual care. And I personally have learned some of the mistakes from that, where it's difficult to make a decision on treating somebody with a serious illness and with drugs that can cause side effects if you haven't seen them face to face. I remember talking to one guy on the phone for the first time in my first meeting with him, and he'd had an operation for lung cancer, and he was going to see me about having chemotherapy. And I had this call on the phone with him, and English wasn't his first language, and he had this gravelly voice, and on the phone it sounded terrible. And I was like, boy, this guy doesn't sound like he's well enough for a haircut, let alone chemotherapy. But I was entirely wrong. I said, at least I had thought, like, I don't want to make this decision without seeing you. I saw him a couple of days later, face to face, and it was he's just got a gravelly voice. He's just got a low voice. He marched in and he was right as rain, and English wasn't his first language. And so, I've learned that, you can't make decisions on the phone. There's a time and a place for virtual visits, but there's a time and a place still to see people in the hospital. And maybe a message to people who are listening is hospitals are pretty safe places to come to. The amount of restrictions on visitors can be very difficult, for mental health, and maybe we can talk about that in a minute. But it does mean there's not so many people going around the hospital. Wherever I go, I've got a mask on. Wherever I'm in front of a patient, I've got a mask with a visor or goggles. Everybody is wearing that. Everything is clean. So actually coming to the hospital is a pretty safe place to be. So if you do feel unwell, if you do have that persistent cough, if you do think you're having a side effect from the treatment, don't stay at home for fear that you're going to get COVID coming to the hospital. You're not. You're more likely to get COVID from being careless at home and going to a party or having too many people come to your house than you are coming to the hospital.
Oh yes, I mean, I'm so glad to hear you say that, because it's striking how, even though it's November and we've kind of have already been through a wave, how little the public kind of understands about the risks of transmission. And I think people are more fearful of the grocery store and strangers than they are of inviting a group over for a party. And I think that's because, I mean, in some ways we're sort of saying, look, I know my circle is safe, but as we've learned with COVID, it's a very sneaky virus and it can sort of get in anywhere, right? And I think that's why we're seeing what we're seeing. Don't want to get too off topic, but
but you're right. We've got to keep your bubble tight right now. Still, we're not in a good place anywhere in the world, really. It seems that numbers are not good right now, and so we've got to be careful. Look for the local advice from your public health office. And so for me, I've got the Ottawa Public Health website right here, and really follow that advice. Use a mask when you're in public, but the message I wanted to get across was that it's safe to seek medical attention, and there's probably a bigger risk of not getting medical attention for the symptoms that you have. That's the bigger risk than maybe catching COVID in a hospital where it's extremely unlikely because of all the precautions that we've got in place.
Right. And, there's actually some questions that have already started to come in. And that's one question that someone had, are you finding yourself, or just, do you still think that patients are reluctant to schedule treatments or schedule appointments? We heard early in the year, of emergency rooms being empty. And basically, so that's sort of a double barreled question. Are you finding that experience of patients being sort of reluctant to come in? And is there a role for governments here? Is it time they start rolling out a campaign to say, hey, hospitals are safe, go see your doctor?
Well, I would welcome something like that. I think, I've been talking with some of our regional partners about trying to get that message out that, if you are not feeling well and you do have symptoms that are worrying for, well, really for any condition, but we're talking about lung cancer. So that persistent cough, coughing up blood, getting more out of breath, you really do seek medical attention, and getting that message out, I think, is is very valuable. Hospitals are really geared to be safe for you. I feel like I might have missed a point of your question though.
No, that I think answers that. And if not, please, to the person who asked it, feel free to ask again. And yeah, keep some questions coming and we'll try and get to them and save some time for them at the end as well. Going back to this idea of a sort of the backlog, and you're saying, some places are now able to basically ramp up capacity in a really huge way. That could change in a lot of places, in the coming months. And I think already, as you say, already has been. How do we, we're not getting out of this anytime soon. I don't care what Pfizer's good news was this week. I mean, this pandemic isn't going away in January, even if a vaccine comes on the market in the next couple of months. We're sort of stuck with this way of life for a bit longer. So how do we manage this backlog? Do you find, are there places that are getting it right? I mean, Ottawa seems like it's, where you are is doing a fairly good job, and you hear good stories from elsewhere. So what can you speak to about this backlog and how we, yeah.
I mean, there are challenges, and for example, places where there are outbreaks in long-term care facilities means that those facilities go into lockdown. And so if there are people who are in hospital who are ready to be discharged, but they can't be discharged because the long-term care facility is closed, so they can't go there, means the hospital fills up, and then it's harder to get people in for their operation. So there's a lot of moving parts to all of this. The Pfizer announcement, of course, was very welcome. And I'm led to believe we're going to get more announcements soon. We have to be cautious. That 90% control from the Pfizer vaccine was in ideal conditions in a trial population of people who were getting regular phone calls, getting their 2 doses 4 weeks apart. We know in the real world fewer people would necessarily fit that criteria. Maybe a lot of people would only get the first dose and then they'd forget to get the second dose or wouldn't want it. We don't have the long-term follow-up yet to see how durable these responses are. But, given all of those caveats, that was good news. Better to hear that news than not hear it earlier this week. In terms of backlogs, I'm not sure if anybody gave you an answer to that you could really take it as gospel, because there are so many moving parts regionally. It maybe, we have to take into account unions. For example, unions have quite fairly protecting their employees who have been under the gun for the last 8 months and working extremely hard. And now we'll have something to say about hospitals saying, well, we now need you to work lots of extra shifts as well. So there's those components, protecting staff from burnout, operating rooms. Actually, do we have the capacity of beds? So, hospitals are looking at using hotels or using other facilities as places where patients who are kind of ready to go but can't be discharged could go and be looked after to free up capacity. So I think, this will also vary from hospital to hospital, from region to region. So I guess my learning from this is, it's kind of amazing what a lot of our hospital leaders have been able to do, and the imaginative solutions that people are coming up with have been really impressive. And I sit in on a weekly cancer executive team meeting here, and some of the people who are trying to figure out these issues around operating room times, getting rid of backlogs, really, I think we can be really pleased that there's some smart, engaged, passionate, hardworking people trying to fix these solutions for all of us as a community. And so, we'll get through it, but the next few months still going to be up and down.
Mm-hmm. Definitely, it's going to be. It will be. I think it'll get worse before it gets better, and hopefully everyone stays safe. We do have some questions that have been rolling in, so I'll move to some of those as well. We have about 10 minutes left, so I don't want to leave anyone hanging. This is an interesting question. Is there anything the public can do to help advocate for early screening? yeah, start some kind of a campaign. I mean, I don't know. I mean,
Yes,
any thoughts
absolutely.
on that?
Yes, please do. If you would like to, we would love that help. And in fact, sorry, I'll mention it for the third time, but lungcancercanada.ca, go to the Faces of Lung Cancer report. And at the end of that report, there are some takeaway sheets of how you can get involved to help. And specifically there about lung cancer screening. You can write to your local member of the provincial parliament. You can certainly get in touch with our office, and I'm sure we can work with the Lung Health Foundation as well. As in fact, we've worked with the Lung Health Foundation on this Stigma campaign called The Wrong Question. You go to have a look at that site, wrongquestion.ca. But in terms of specifically for screening, yes, the more voices, I think, the better, and we've got these tools to help. You could join, if you like, the Hope Army, which is again, you can see that on the website, hashtag Hope Army. But this is again trying to build this well, Hope Army, if you like. I mean, this is trying to build a collaboration of volunteers to support these initiatives.
Those are some fantastic ideas, and it's really nice to see some lung cancer advocates filling that space. So that's really exciting, and hopefully we'll see more of that in the coming years, and get those screening programs up and running. A couple of more questions. This one's interesting. I hadn't thought about this, but it goes part and parcel with treatments being canceled, clinical trials being postponed or canceled. And is that happening? What's the impact on patients? And is that still happening?
Yes, this was one of the certainly collateral damage back in March, was that a lot of clinical trials just closed down, or not closed completely, but were put on hold. A lot of trials with newer treatments and new drugs that look extremely exciting and promising for lung cancer, or indeed any cancer, because they're new, there's always a lot more effort in terms of making sure people are safe when they're receiving newer drugs or experimental treatments. But what that involves is often more trips to hospital, more blood tests, more biopsies, more scans. And at the time when this all hit, and we were trying to really restrict the number of people coming into the hospital and protect people from multiple visits, a lot of trials were put on hold, plus a lot of clinical trial staff were redeployed to other areas. So the good news is now trials are back up and running. It will again depend a little bit on the center that you're in, but most clinical trials offices now have got most of their trials back up and running. We've just opened a study in lung cancer specifically for people starting treatment, looking at a COVID vaccine as well, alongside their cancer treatments. So that's back up and running, but along with screening, the screening programs that were put on hold, that was a disappointing reality of that sort of March to July, August time period.
Definitely. Well, that's encouraging to hear that things are sort of back up and running. And I think, one benefit of being in this so long is we are learning how to safely sort of navigate this new world. So that's exciting. Another question, hearing about some hospitals that, have been on redirect or in crisis, and what does that mean for lung cancer patients, for all, for treatment, diagnosis, surgery, everything? And is that sort of still the case, I guess?
I think now most places now lung cancer diagnostics are going well. So if you need a biopsy, you get your biopsy. There have been some delays in getting scans. We just learned that Ontario is putting more money into scans to try and address some of those backlogs. The treatments, we've been able to keep going. Surgeries are happening by and large in most places now. So I would be try to send a reassuring message here that, at the moment, things are in most places mostly on track, and any treatments that are being deferred because of the pandemic, it would be after a discussion between patient and their physician to say, look, on balance, it's better for their health not to have a treatment than have it. But we're not really at the point where we're having to say to anyone, I'm sorry, you just can't have this. So, I think things are largely going on track because we've got a lot of these extra precautions in place. Did that answer the question?
It did, and it actually is a perfect segue to the next question from the audience. Yeah, you couldn't have answered it better, actually. So, we've heard some of these sort of, dire scenario plannings for what will happen if the hospitals are at capacity and sort of, rationing care and treatment and things like that. Some very scary ideas. So the question is really, if we're in a situation where, hospitals are simply full, they're at capacity, what sort of plans are in place or things can be done to make sure or help prevent this situation where lung cancer patients aren't able to get their treatment? I mean, is there a plan in place to help keep patients on the right track with their treatments and things?
Right. Yeah, so maybe I'll just speak to the sort of the outpatient treatments to start with. So chemotherapies, radiotherapies. There's been a lot of very thoughtful work going into this. These are not back of the envelope solutions. The National Health Service, BC, CCO, that's Cancer Care Ontario, have all come up with some very thoughtful ways to help us prioritize. So if we really can't treat everybody and we've got to call some people and say, look, you shouldn't come for your treatment today, we know exactly who to call. And if you get that call, it's going to be, it's not a lottery that your names just come out of the hat. It's going to be because, your treatment has been, thoughtfully, assessed to say, actually, you know what, that one can wait. So for example, if somebody's been on treatment for 12 months and their cancer's been stable for 12 months and has responded very nicely, well, that next treatment next Tuesday is not so crucial. That could maybe wait or be skipped. If you've just been diagnosed, however, and you're going through treatment with the goal of a cure and keeping it all on schedule is really important, then you're going to be at the top of the list to keep going with treatment. So those kind of processes are all in place for chemotherapies and radiotherapies. We go through mock exercises. Unfortunately, we've not had to implement that so much. Now, if you need to be in hospital, if you're that sick that you need to be in hospital, come to the emergency department and you'll get a bed. Now, is it going to be perfect and smooth? No, it may not be. It may be that you don't get the bed for a bit longer than you would have if it really becomes very tough. But still, I would suggest that if you're really unwell, you're safer in the emergency department with 24-hour nursing and medical care than at home really ill. And the hospitals, I think I mentioned this earlier, are really focused on looking at alternatives to ensure that we still have beds available. And whether that's opening a hotel or some hospitals are putting up facilities in their parking lots. So, hospitals are really working on this. So I think I just want to try and get the same message. If you feel unwell, come to the hospital, you will get treatment. It might look a little bit different, but we will do everything in our power to make sure things go safely and well.
That's great. And we have about, a minute or so left. So I think this is a nice place to leave it with the last question. And basically from the patient perspective, what message would you give to patients, how they can prepare for the idea of another potential lockdown in, places like Ontario, any upcoming challenges you think they should just basically get ready for?
Well, I think that probably goes to all of us, doesn't it? Whether we have cancer or not, that we're all at a place where our lives are different right now. My family's in the UK. I was meant to be going there at Christmas, and I'm not going. So, I think the things that we can all do are the things that we've been hearing about for 6 months, 9 months. Wear a mask when you're in public. Social distance from people. Keep your bubble tight. And then the cancer component, I know I'm being repetitive here, but if you're not feeling well, seek medical attention. And, by hook or by crook, we'll get you through.
Wonderful. Well, I just wanted to thank you very much. This has been a fantastic discussion, and hopefully, we'll help those who have been listening in navigate the next few months. Hope everyone stays safe. And I wanted to also thank the sponsors of this event, AstraZeneca Canada and Takeda Canada. And yeah, please stay tuned for our next policy series that we're going to be doing later this month. Thank you all.
Thank you.
Okay, so Dr. Wheatley Price, I will let you off the hook here, and thank you so much. And yeah, and hopefully I'll be in touch in the coming months. We can do a story together on the need for more screening. So
Yeah. And you know what we didn't touch on, or we didn't really get into, was the mental health impacts of this, and people in hospital who can't, no one can visit them, but maybe there's a mental health story about COVID as well.
I think there is, and you know what, it's such a huge issue. So yeah, we'll be covering this for years to come. So yeah, thank you again, and all the best.
Thanks, Carly, and thanks, Jessica, for setting it up.
Thank you. Take care.
Bye-bye.
Okay, yeah, end it now. Thank you.